Okay, so as we already know, we've talked about water compartments, okay, but we also have electrolyte compartments. So the electrolytes are also compartmentalized. So for the electrolytes, we have the cations and then the anions, okay, and we must know where these are in abundance, okay. So for example, we must know that when we take the cations, sodium is the most abundant extracellular cation, okay, and potassium is the most abundant intracellular cation. So that's the first point, the first principle that you should know. Sodium is more on the outside, potassium is more on the inside. That's the first principle. The second principle you should know is that what is maintaining this is the sodium potassium pump. So the function of the sodium potassium pump is to maintain this separation of charges, okay. The third principle that you should know is that when you take an anion, when you come to the anions, okay, the anions, we have anions like bicarbonates and chloride. Okay, so bicarbonate and chloride are the bicarbonates and chlorides are the most. Okay, someone said I should go over it again. So I'm saying that the principles are this. That's one, for the electrolytes, we have cations and then anions, okay? And we must know where these are located or where they are abundant. So first principle is that sodium is more on the outside, okay? Sodium is abundant or is the most abundant cation in the extracellular compartment, whereas potassium is the most abundant cation in the intracellular compartment. So inside the cell, in the intracellular space, potassium is more. Okay. And the second principle is that what is maintaining such separation of charges is the sodium potassium pump. So the sodium potassium pump maintains the separation of these cations, the sodium and potassium cations. Okay. And when you come to the anions, we have chloride and then bicarbonates. Those are the two major anions that we, or let me add, yeah, the two major cations that we'll be talking about, chloride and then bicarbonates. Okay, but there are some other anions like proteins. So proteins are also negatively charged. If you remember, proteins are negatively charged. So proteins also account for the anions. Okay, so let's look at this slide. So this slide is giving us the plasma and inside the cell. Okay, so let's start from the plasma, which is part of the extracellular fluid. That this is the cation. Okay, so the first bar is the cation, then the next one is anion. Here to cation and anion. Okay. Okay, good. Oh God.
When are these starting? When are these starting the exams? Sorry. Okay. But when are these? Oh,
Please, sorry, my network was misbehaving as usual. Okay, good. Oh God. Why? Okay, sorry, my network there. Yeah, so let's continue. So I was saying that if you take this graph over here, okay, this side is plasma, and then this side is the intracellular compartment. Okay, so you notice that when you take the plasma, and as I said, the first bars are for cations, and then this for anions. When we take the plasma level, you see that sodium. Look at the level of sodium. Okay, sodium is very high. Okay, then followed by potassium, then calcium, then how do you call it? Magnesium. Okay, then when you come to the intracellular compartment, you know that potassium is the most abundant cation in the intracellular compartment. Then sodium is here. Then magnesium too. We have some level of magnesium. When we come to the anions, look at chloride is the most abundant anion in the how do you call it, in the extracellular compartment. Okay, followed by the bicarbonates. Then we have some other, like the proteins that I was talking about, negative charge, and there are some other ones, organic acids, sulfates. They are all anions. Okay, then when you take the intracellular compartment, know that the proteins and then the phosphates, okay, they form higher amounts. Now these phosphates, remember that these phosphates are coming from the DNA. If you remember, the DNA has a phosphate backbone, and then we know that the majority of this, or the DNA, is found inside the cell. Okay, so that's the reason why we have high phosphate levels over here, because the cell has a lot of DNA. Okay, and then proteins to inside the cell. There are a lot of proteins over there. Okay, the bicarbonates and then the chloride level, as you can see, they are small. Okay, so this should guide us as we continue. Good. Now there is a concept that I want to introduce. Okay, there is a concept that I want to. I've already talked about all these things. Let me introduce this concept. let me introduce this concept. Okay, this side. Okay, so this side. Let's focus on this side. Now, it's saying that, okay, the concentrations of cations, okay, are slightly lower, okay, in the interstitium than the plasma. So when we take the plasma and then the interstitium, okay, we know the plasma and the interstitium are all part of the extracellular fluid, and they are separated by the capillaries. So the capillaries separate plasma from the interstitium. Okay. Ideally, the water component and then the ionic component should be the same for the interstitium and then the plasma. Okay, but there's some differences. The difference is because you see most of the proteins are within the plasma, not in the interstitium. Like albumin is in the plasma, but it's not found in the interstitium. Remember that we don't want proteins to be found in the interstitium, because if proteins are found in the interstitium, the proteins will pull water there and then it will cause edema, increasing the oncotic pressure in the interstitium. So we don't want proteins to be found in the interstitium. So majority of the proteins are found in the plasma. And because the proteins are negatively charged, okay, most of the cations prefer to stay in the plasma because of the negatively charged proteins over there than the interstitium. So when you compare the interstitium to the plasma has high cation levels as compared to the interstitium. Okay, so that's why he's saying that here he's saying that the concentration of the cations are slightly lower, okay, and those of the anions are slightly higher in the interstitium than the plasma. This is what is called the Gibbs-Donald's rule, okay, and this is because of the presence of cells and then and also proteins in the plasma. Okay, so that's a concept that I wanted to emphasize. Okay, good. So now you see, when it comes to measuring the osmolarity, I told that the osmolarity or the osmolality, okay, is about exactly 285, okay, but it's approximated to 300. You see, you can take someone's blood sample and then ask them to give you the exact osmolarity, okay? But even if you don't have it, you can approximate, okay? So there's a formula for approximation. That is when you know the person's sodium level and you know the person's urea level and you know the person's glucose level, you can find the osmolarity. So it's given by 2 times the sodium level plus the urea concentration plus the glucose concentration. Okay, that will give you the osmolarity. Okay, so for example, there's a question here. Someone, if you are looking at a person's labs, okay, the person's electrolyte labs, and they ask you to calculate the osmolarity. Okay, all you do is just take the sodium 135, multiply it by 2, then add the glucose and then the urea to it. Okay. So that's how we find it's okay. But if you don't have the sodium, if you don't have the glucose and the urea, you can just make it twice the sodium level. Okay, someone have a question. Okay, so someone is saying that is the osmolarity and osmolality the same or they are different? They have the same concept, but they are different. Okay, the difference lies in the units. Osmolarity is mole per per liter. Okay, then the osmolality is mole per kilogram of water. So the difference is that for the osmolarity, we are using the volume of water. So mole per liter, okay, and then for the osmolality, we are using mole per kilogram. Okay, but usually we prefer osmolality because when it comes to water, the volume of water is affected by temperature, but the mass of water is constant, independent of temperature. Okay, so that's why most often than not, we prefer to use osmolality. Okay, but they are usually they are almost the same concept. Someone said I should go over the Gibbs rule again. Yeah, the Gibson's rule. So we are saying that the the cations, okay, are more in the plasma than the interstitium. That is the rule. And the rule is, and this is because the plasma has proteins. So there are proteins which are negatively charged. And you know that unlike poles attract, okay, so the cations will prefer to stay within the plasma where the negative charges are. Okay, and in so doing, you notice that the plasma has high concentration of cations than the interstitium. Okay, I've answered your questions. Good. Now there's a concept called the osmolar gap. Now this is this you see. So I told you guys that you see the lab can measure the osmolarity or the osmolality. Okay, but if it doesn't do it, okay, then you as a clinician can estimate it by using the formula 2 times the sodium plus glucose plus urea. But at times, and ideally they should be the same, okay, but at times the measured osmolarity is different from the calculated one, and that difference is what is called the osmolar gap, okay. And then this difference is as a result of presence of alcohol or other chemicals that exerts osmotic activity. So you notice that when they are taking someone's blood sample, okay, notice that they will use alcohol to wipe that area. Okay, if you use the alcohol to wipe that area and you don't wait for it to dry, and you take the blood sample, okay, and then you manage to get some of the alcohol inside the blood sample, the alcohol will also increase will also add an osmolarity effect. Okay, and that will increase the osmolarity. So you realize that the measured osmolarity will be higher than the calculated osmolarity because of the influence of the alcohol which is present. Okay, good. So now let's with this concept, let's go to the electrolytes. The first electrolyte we are going to talk about is sodium. Okay, now what's I mean the ones over here, just read the concept. Okay, what I want to emphasize is that note that the plasma, as I said, the plasma sodium levels, okay, is between 135 and 145 millimole per liter. So if you take someone's blood sample, okay, and then the lab request comes, it's supposed to be between 135 and 145. If it's less than 135, we say the person has hyponatremia. If it's more than 135, the person has hypernatremia. Okay, and most of the salts that we take in are from the food we eat. Okay, and then we lose salt either by urine or by sweating. Okay, and even if someone has diarrhea or vomiting, they can also lose sodium by those mechanisms. Okay, and I have also emphasized that aldosterone is for reabsorption of sodium. Okay, so let's note that. Now, what is the function of sodium? As I said, remember that sodium is the main volume regulator of the extracellular compartment. If your sodium levels are low, okay, it will affect your extracellular fluid, because wherever sodium goes, water goes. Okay, so remember that if they ask you which ion regulates the extracellular fluid volume levels, the answer is sodium. Okay, good. And then I've already talked about how sodium is regulated by aldosterone. So aldosterone leads to reabsorption of sodium at the expense of potassium and hydrogen. You see, this is very important. At the expense of potassium and hydrogen. Okay. And then remember that the NAP, atrial natriuretic peptide, okay, that one leads to excretion of sodium. Okay, so that one will cause you to excrete sodium, unlike the aldosterone, which will cause you to reabsorb sodium. Okay. And then vasopressin 2 also indirectly affects sodium levels. Okay. Just know that I've given you the reference 135 to 145, and is determined by the flame photometry, or the ion selective electrode. Okay. Now, if you remember from SHS, we use flame test to test for cations. Okay, so remember you also use the flame photometry or the ion selective electrode to determine the sodium levels. Okay, I'm sure you've seen this in the instrumentation. Okay, now there's also another concept I want to 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 bring about. Okay, now this is the concept. For example, you measure someone's sodium levels. Okay, the person is fine. You measure the person's sodium level, and you are getting something like 110. You see, this person is severe. You think that this person is severely or has severe reduced sodium level. Okay, 110. We said the range is 135 to 145, and you measure this person's sodium levels, and it's like 110, and you are worried. Okay, but you have to be very careful in the interpretation of the data or the lab reports. Okay, because there is a concept called the solvent exclusion principle. Now, the solvent exclusion principle is this. You see, the concentration of sodium we are talking about is with respect to water. So we are looking at how much sodium is dissolved in water. But if there is a case where you have other solvents, like you have a lot of proteins or plasma proteins, or you have a lot of fatty acids, lipids, what's going to do is that the proteins and the fatty acid will increase the volume. So let's say I have sodium to be 135. Okay, 135 moles of sodium in 1 liter of water. So the concentration will be 135. Let me use millimoles per liter. Okay, so that's my sodium concentration, 135 millimoles in 1 liter of water. Now here is the case where now I have additional fluids like lipids and then proteins. So let's say those ones also give me 0.5 liters. Okay, so now when you take it to the lab for them to measure, what they are going to measure is the sodium that you have divided by the total volume, which is water plus lipid plus the proteins. That's what the machine is going to give. So that means that the concentration of sodium that you are going to get is reduced. You get something like 135 over 1.5, okay, whatever that answer is. So whenever someone comes with a reduced level of sodium, like 110, always go and check the lipid levels as well as the proteins level. Okay, so because if you have high lipid level and high protein level, they will give what is called pseudo hyponatremia, false assumption that the person's sodium levels are low. This is what is called the solvent exclusion effects. Okay, so you have to correct it as a doctor, okay, by subtracting. There is a formula for it, okay, but don't worry about that. So that is the principle that I've given you. Okay, that is the principle that I've given you. Please, is it clear? Someone's hand is up. Do you have a question? Okay, please, is it clear? I want to respond so that I can continue. Is it clear? Okay. No response.
Yes.
Okay, good.
Yes.
Okay, good. So I have explained this concept. Okay, someone, there's a question. Okay, good. Okay, so for example, there's an illustration here that you measured someone's sodium level and it was 120. Okay, then not knowing that this person has multiple myeloma, and I'm sure you guys know that multiple myeloma, you have a lot of proteins, okay, and lipid disorder. Then later on, they notice that the water is 85%, then the lipid is 15%. So you have to correct this, because the sodium that we want should only be how much of it is dissolved in water, not how much of it is dissolved in all the other solvents, okay? So then you have to correct this by the factor. You multiply it by 180 over, sorry, 100 over 85, okay? The correction factor. And then you notice that now the person has 145 millimoles per liter, and you have to add this of water, okay? That shows us that you have corrected this of water instead of serum, which is the normal ones that we talked about, okay? So this is given, this is a good example of false or pseudo hyponatremia, as I have explained. So disorders of sodium. One, hyponatremia. Okay, so now if someone has hyponatremia, first of all, rule out the solvent exclusion principle. Okay, rule that one out. And then secondly, what you have to do is that you have to check the person's clinical presentation. Okay, one, it could be that, okay, this patient's, okay, you let me make it orderly. Okay, so if this person has hyponatremia, okay, what could it be? It could be that one, the person has a lot of water. Okay, so the water retention has reduced or has diluted the sodium. That's the first thing that should come to mind. Then the second thing that should come to mind is that the person is actually losing sodium. Okay, so it could be that the person is actually losing sodium, or the person's sodium levels are normal, but the person has excessive water which has diluted the sodium. So there are two main things that you should look up for: retention of water, and then two, loss of sodium. So now let's look at retention of water. So if the patient has retention of water, okay, that means that the water is going to dilute the sodium levels, and it will give an assumption of hyponatremia. Okay, so now if this person has water retention, you have to know whether the person has edema or not. So when we say edema, it's just by clinical observation. Okay, you maybe they will teach you how to check for edema in the clinical, yes. So you press the person's leg and see whether it will pit. Okay, we call it pitting. So when you, for example, when you press your skin, okay, it comes up, okay, but those with edema, okay, when you press it, it doesn't come back easily. It takes long time for it to come back. Okay, so that's called edema. Okay, so please, we have 1 minute remaining. I want us to end here, okay, so that we continue tomorrow. So tomorrow you pick it up from this part, then we add the renal part to it, okay. So the acid base disorders, okay. Please, is it clear? We'll continue tomorrow, okay. So use
Thank you.
yes, use the rest of the time to learn effectively. Okay, all the best.
Thank you.
Thank you.
Love.